She is a clinical pharmacist specialist in antimicrobial stewardship at Rainbow Babies and Children's Hospital. She completed her pharmacy doctorate at University of Kentucky and residency at the VA Western New York Healthcare System, and further specialized in infectious disease at Louis Stokes Cleveland VA Medical Center. She has been published and presents nationally. She was recently awarded the Quality and Patient Safety Poster Award. Everyone, please welcome Dr. Moore.
Everyone, thank you for that introduction. Today's title of the presentation is to treat or not to treat. That is the question. So for today is define antimicrobial stewardship and what are the components of an antimicrobial stewardship program. Lines that provide recommendations for common pediatric infections. And we will discuss different patient cases to determine when antimicrobial use is appropriate. Young groups of antibiotic prescriptions. At least 29% of all outpatient antibiotic prescriptions are unnecessary, and there have been some studies that suggest that up to 50% of all antimicrobial use is unnecessary or inappropriate. The use of antimicrobials leads to resistance, and this is an issue because we only have a finite amount of antibiotics to treat different infections. In 2009, there was a paper published in the Infectious Disease Society of America, and it described these escape pathogens. So these are Enterococcus faecium, Staph aureus, Pseudomonas aeruginosa. All of these are pathogens that have very limited treatment options and have developed over time. Bacteria has been described to cause 2 million illnesses annually in the United States associated with excess morbidity and mortality. Graphic here because it really gives a good graphic of the situation that we have at hand. To orient you to this graph, we have time on the x-axis. On left to your right, it's the percentage of antibiotic-resistant bacteria over the years. And on my right to your left is the number of antibiotics approved. So as you can see, that yellow line, the increasing amount of methicillin-resistant Staphylococcus aureus. The green line is the increasing amount of vancomycin-resistant Enterococcus. The dark line is the increased amount of fluoroquinolone-resistant Pseudomonas. And Pseudomonas resistance is very concerning because currently we only have fluoroquinolones are the only option for Pseudomonas. So if we wipe those out, there will be no options for that, and patients will have to be admitted if they have a Pseudomonas UTI or any other infection. The going down is the amount of companies have decreased that are actively researching and trying to develop new antibiotics. So in 1990, there were 18 companies that were actively researching antibiotics, and in 2011, there was only 4 companies. This graph here, once again, goes to show that there has been a decrease in amount of antibiotics that have been approved in the United States. So we have them on the x-axis and the number of antibiotics approved on the y-axis, and then we have the colors that denotes the different type of antimicrobials that have been developed. We have the green is the lipopeptide, so that's pretty much gram-positive active agents. And what's notable here is that these drugs that have been developed are decreasing, and there's not any of new novel mechanisms of action. And so the bacteria already have seen a beta-lactam. They've already seen a lipopeptide, so they already know how to develop resistance against the bugs the antibiotics that we have. Due to this decrease in 2011, there's been a push by the United States government, by the World Health Organization, to really give incentives to drug companies to develop antibiotics because it's not really profitable for them. So if someone has a urinary tract infection, they're going to get 7 days of treatment. There's not a lot of money in developing that. But if they put all of their money into something like diabetes, they're going to be on that drug for the rest of their life. So that's where the money is. So they've given these incentives to develop antimicrobials. So in 2011, 2014, we have seen an uptick in the amount of drugs that have been approved by the FDA. So Vancin, these are long-acting Staph aureus drugs or gram-positive agents. Tazolid is another gram-positive agent. And then Tolozone tazobactam is a novel cephalosporin that has enhanced activity in Pseudomonas, and tazobactam is a beta-lactamase inhibitor. Of note, these drugs, although they're newly approved to help fight some of our more resistant organisms, There's limited studies in pediatrics, so they're ongoing. So even though we have these new drugs that are being approved, pediatric data is not there yet. And we have ceftazidime avibactam, another drug that is being used for resistant gram-negative organisms. And then recently, in 2017, deloxacin is a new fluoroquinolone. It has activity against MRSA and Pseudomonas, so it has very broad spectrum activity. And vaibarbactam is another negative act agent. The vaibarbactam is an inhibitor that is stable against different resistant mechanisms. This relates to the association between antibiotic development and resistance. So as soon as we get another antibiotic developed, the bacteria are going to live too, so they develop resistance to it. So penicillin was widely used in 1943. Penicillin and Staphylococcus aureus was soonly detected after that. In order to treat penicillin-resistant Staphylococcus aureus, methicillin was developed. That was broadly used in 1960. In 1962, methicillin-resistant Staphylococcus aureus was isolated. So as you can see, we can't really keep up with the bacteria, their resistance mechanisms. This antimicrobial stewardship, and why do we need it? It is an intervention to improve the use of antimicrobials. You want that the patients are on the right antibiotic for the right indication, right dose and duration. Some antibiotics is not, so what is a little antibiotic going to do? And that's really an issue that we have. So misuse can lead to the development of multi-drug resistant pathogens that we just talked about are very difficult to treat. Adverse drug events and toxicity. There is a report that 1 in 3 emergency room visits are directly related to a patient having an adverse event associated with an antimicrobial, and there's also excess mortality and cost associated with antibiotic misuse. The stewardship program is to optimize clinical outcomes for patients, to minimize unintended consequences such as adverse drug events and the emergence of resistance. Antimicrobial stewardship team should be multidisciplinary in nature, with the focus on the patient being our primary goal. So they're infection preventionists who track the resistance and hospital-acquired infections like Clostridium difficile. A physician should be a physician champion for the stewardship program. Clinical pharmacists with expertise in infectious diseases. Microbiology is very important for the development of an antibiogram. Also the utilization of rapid diagnostic technology. So if you have a patient with bacteremia and it's used gram-positives, we have rapid diagnostics to determine if that's Staph aureus or coag-negative staph. And then with the Staph aureus, you can have detect resistance mechanisms to determine if it's MRSA and MSSA. And so you really, with those rapid diagnostics, get patients on effective treatment faster. And the hospital administration needs to be in support and provide funding and resources for an antimicrobial stewardship program. Primary strategies for any stewardship program, these include formulary restriction and pre-authorization and prospective audit with intervention and feedback. Formulary restriction is restricting your very broad antimicrobials such as carbapenems for specified use to make sure that those are not being used inappropriately, and then pre-authorization, similar to that, we have to have a specialist to use that antimicrobial. With intervention and feedback is having someone review a patient's antimicrobials on a regular basis and then providing feedback to the prescriber saying, you have this Klebsiella pneumoniae, you currently have your patient on piperacillin tazobactam, and be more appropriate because it's susceptible to cefazolin to use a more narrow spectrum agent. Strategies for stewardship programs include education of providers on microbiologic data and local resistance patterns, and then also the development of clinical guidelines to really guide appropriate prescribing for various infections. So now transition to the treatment of common pediatric infections, and these are all based on Infectious Diseases Society of America guidelines or the American Academy of Pediatric guidelines. So talk about is upper respiratory tract infections. So this is a specific term used to describe acute infections, most likely called the common cold. Transmitted by aerosol droplet or direct hand-to-hand contact. The pathogen invades the respiratory epithelium, and then it is more likely to be contracted in crowded conditions. Children have respiratory tract infections a year, so you can see how highly communicable the upper respiratory tract infections are. And then the signs and symptoms are varied: throat irritation, cough, congestion, and runny nose. But those upper respiratory tract infections, rhinovirus being the most common cause, with viruses as well. We worry about RSV, and particularly in the neonatal population. Rhinovirus has also been described as another emerging pathogen for very severe respiratory disease. Different viral upper respiratory tract infection and a bacterial infection may be difficult, but it is very important to ensure that we are not using antibiotics appropriately, because we all know that for a viral infection, an antimicrobial is not going to work. So symptoms that get more likely to be a bacterial infection include symptoms that have been occurring for more than 10 days, and the symptom onset was very severe, with high-grade fever. And lastly, the hallmark sign is that the patient hasn't been feeling well, they start to feel a little bit better, and then they suddenly get worse again. Bacterial rhinosinusitis in children is 7 years of age, and this is directly related to the development of their sinuses, and it's likely to be viral in children less than 2 years of age. It's important to target and know the organisms that cause a specific disease, because that is where your antimicrobial treatment is going to come from. So for bacterial rhinosinusitis, you're primarily worried about strep pneumoniae and strep pyogenes. For gram-positive organisms, you worry about H. influenza and Varicella catarrhalis. And then there's also anaerobic pathogens that you have to worry about that colonize the nasal tracts, and that's Bacteroides and Fusobacterium. If it's true bacterial, it'll be amoxicillin clavulanate as the first line, and then we have recommendations for patients who are tolerant to penicillin or if they have severe beta-lactam allergy. And amoxicillin is going to cover your gram-positive organisms, so your strep and your strep pyogenes and your strep pneumoniae, and then it'll also cover your gram-negative, so your H. flu and your NCAT. The clavulanate makes the more stable against H. flu. They produce beta-lactamase, so we know beta-lactamase is an enzyme that cleaves the beta-lactam ring and to make the amoxicillin by itself inactive. So you make sure if you have true bacterial rhinosinusitis that you use amoxicillin clavulanate as your first agent. That is, some say 5 to 7 days, and some say that is more appropriate to treat for 10 days or more. You know which antimicrobials are not ideal for acute bacterial rhinosinusitis, and this is primarily the macrolides such as azithromycin. Azithromycin is one of the most commonly prescribed antimicrobials, and it has increasing resistance for the organisms that we primarily worry about for respiratory tract infections. So high resistance to strep pneumo. It has high resistance also to H. flu, so not ideal agent for rhinosinusitis. Trimethoprim or Bactrim is also the ideal agent because it's a very poor agent against Streptococcus species, and there's also increasing resistance to H. influenza. Parents or patients with adjunctive therapy is always a good idea, and so for acute bacterial rhinosinusitis, saline irrigation provides a great amount of symptomatic relief, as well as if patients have rhinitis, intranasal corticosteroid will also be helpful. Next item. So Streptococcus is the most common cause of bacterial pharyngitis. There is a pharyngitis that is caused by a virus, and so it is important to discriminate if it's bacterial in etiology by throat culture, which takes a little bit longer. So PCR or the rapid antigen detection test is used most frequently. Symptoms of viral pharyngitis includes oral ulcers, hoarseness, and rhinorrhea. Viral pharyngitis is more common in patients less than 3 years of age. Group A strep is one of the few organisms that is exquisitely susceptible to our antimicrobials, so amoxicillin is the treatment of choice for that, or a one-time dose of penicillin G. These are the alternatives if the patients have allergy. Azithromycin is probably the only time you would use it for allergy because since the group A strep, and I've said it's very susceptible, azithromycin still works for that, but not really for other like strep pneumo or H flu with the increase in resistance. For parent episodes of pharyngitis, it's always good to determine if they're a chronic carrier because there is a good amount of the population that carries group A strep normally, and that doesn't necessarily mean they have an active infection, need treatment, and then the duration for group A strep with amoxicillin is 10 days. It'll be a one-time dose for the penicillin G. Adjunctive for group A strep include symptomatic relief with analgesics. Otitis of symptoms and inflammation in the middle ear, and it is the #1 reason why children are prescribed antimicrobials. There's a discussion on who should be treated for acute otitis media, and there's been discussion on watchful waiting, and so we'll talk about watchful waiting next. But sometimes acute otitis can resolve on its own, and so it doesn't always require treatment. But those patients who should be treated as soon as they are assessed are patients with severe bilateral or unilateral, and severe is defined as moderate severe pain for more than 48 hours and a high-grade fever. Patients less than 2 who have bilateral AM should definitely be treated as well. Waiting has been evaluated in multiple studies, and candidates that you can say did it on its own. We're going to wait a couple days to see if it improves by itself without an antimicrobial. Include those patients who are 6 months to 23 months, so it's unilateral and not bilateral, so that under the age of 2. And the patients who are older than 2 who have bilateral or unilateral, the older patients can be considered for waiting a couple of days to see if there's symptom improvement without an antimicrobial. Associated with acute otitis, the #1, PIN, gram-positive strep pneumo, strep diogenes could also be a factor, and then negatives are H. influenza and varicella. Acute otitis, first line is amoxicillin, and those patients who have had an antibiotic failure, if they present with purulent conjunctivitis, or if they received amoxicillin 30 days prior for any other indication, then amoxicillin clavulant should be used, basically to decrease risk of amoxicillin being ineffective if they have a resistant H. influenza or if their strep pneumo has become resistant to amoxicillin alone. Adjunctive otitis is once again symptomatic relief with analgesics. Next, community-acquired pneumonia, tract infection, and it is the leading cause of mortality in children worldwide. Signs include plus or minus fever, obviously increased work of breathing, abnormal absent breath sounds. Symptoms, patients who are more likely to have an atypical pneumonia. This is characterized by a slowly progressing process, sore throat, plus it's a fever that develops over 3 to 4 days. Associated with community-acquired pneumonia, the #1 pathogen is strep pneumo. Aureus is also becoming more a pathogen for pneumonia. And the atypical organism we worry about in children is Mycoplasma pneumoniae. Also, you can worry about chlamydia pneumoniae as an atypical pathogen for pneumonia. Human pneumonia include once again amoxicillin because your primary agent that you're targeting is strep pneumo. And luckily in our area we do not have a high resistance rate of strep pneumo, so amoxicillin is appropriate. If the patient is ill enough to be admitted, ampicillin would be the ideal agent for that. For beta-lactam allergy, Levofloxacin, which is fluoroquinolone, has really strep pneumo coverage. That's why it's called it's a respiratory fluoroquinolone because of its enhanced coverage against strep pneumo. And then for patients with atypical pneumonia, this is commonly in patients who are older, so greater than 5, so school-age children. The treatment for that is azithromycin. It's a very potent mycoplasma. In cases, so in mid-January, an 8-year-old boy presented with nearly 2 weeks of worsening nasal congestion, right cheek pressure, and cough. He had intermittent fevers during this time as high as 102. There was an improvement in his symptoms, and then they suddenly worsened. The parents bring him to the ER for evaluation. The patient does not have any drug allergies, and the patient is up to date on all immunizations. Do you think this patient should be treated? Raise your hand. And we'll leave diagnosis for this patient. So, because it's been going on for more than 10 days, he's been febrile. The hallmark symptom is he improved and then he got worse again. Would appropriately treat him since he does not have allergies. Amoxicillin clavulanate would be the ideal agent, and that is the first line of recommendation by the guidelines. Next, a 4-year-old girl is brought to her primary care provider by parents. For the past 2 days, the girl has complained of a sore throat associated with rhinorrhea and hoarseness. A rapid group A strep was performed and was negative. Parents admit that the patient needs antibiotics. The patient reported allergy to amoxicillin, and the patient is up to date on all her immunizations. How many say yes? How many? No, it was negative, and then she has very violent symptoms with the rhinorrhea and the hoarseness. So it's variable. Some say 10 days, and then some say that you can possibly get away with a shorter treatment option, but most providers would do 10 days, and either recommend that even after they have felt better to proceed for another 7 days after that. A 12 to urgent care with parents with complaints of left ear pain that developed 12 hours prior to admission. The patient is afebrile. Examination of the tympanic membrane is normal. Patient is up to date on all immunization and does not have any drug allergies. Respiratory, how many say yes? Okay. So the hallmark here is only in her left ear, so that's unilateral. Her tympanic membrane is normal, and she's 12 years old, so that's a higher end of actually having otitis. If her tympanic membrane did look bad, she's still a candidate for watchful waiting. We're waiting for that 48 hours to see if it improves on her own because she's older and it's only one-sided. 9-year-old boy presents to primary care provider's office with increased work of breathing, cough and fever, high-grade fever, has decreased oral intake over the past 5 days, lower absent breath sounds on the right, and the patient is unvaccinated and has reported anaphylaxis to beta-lactam. How many would say yes? Diagnosis. Increased record of breathing. He's unvaccinated, so when you have a patient that's unvaccinated, this is strep pneumo, which can be very burdensome for patients, and since he has a true anaphylactic reaction, levofloxacin would be the drug of choice for him. So we went over a couple of cases. You're not going to always know what the patient has, or for different syndromes that we didn't discuss, we would transition to how you can choose empirical treatment. So this our diagram for Rainbow Babies and Children's Hospital of 2017. So this is put together by the microbiologist every year, and it gives you all your isolates for the previous year. So to orient you to this, we have our bacteria going down on my left to your right that were isolated out of a blood culture over that year, over different classes of antimicrobials. And there in the inside is your percent of isolates that were susceptible to each antimicrobial. So if we look, the third one down is E. coli. There are 520 isolates of E. coli, and our susceptibility to cefazolin was 90%. Our susceptibility to other organisms are up to, or other bacteria are up to 100%. So if you have a patient that's presenting with a urinary tract infection, this antibiogram or what would be appropriate empirical therapy can help guide you with that. So it remains the most common cause of urinary tract infection. Our local antibiogram, 90% of all the life susceptible to cefazolin. So you can assume that cefazolin is a first-generation cephalosporin. So the option in cephalexin is a first-generation cephalosporin. That may be an appropriate empirical treatment option for that patient until you have your susceptibilities back. For organisms, once again, same, your bacteria that has been isolated the previous year and your classes of antimicrobials on the top. So for Staph aureus, it was 650 Staph aureus isolates, Staph aureus that were isolated, antibiogram. Vaccine is still 100% for patients requiring inpatient use. For our more patient use, Bactrim is still 97% susceptible, even though the antibiogram does not state how many of these are Staph aureus are methicillin resistant or methicillin susceptible. At institution, there's about half, 50-50. So half of our Staph aureus is MSSA, half is MSSA. And then for clindamycin, it's 70% susceptible to all Staph aureus isolates. With the skin and soft tissue infection, Staph aureus and Bacillus streptococcus remain the most common causes for skin and tissue infection. If you have a high suspicion that this is Staph aureus, so Staph aureus is known to cause carbuncles and more pussy type of conditions, for lack of a better word. So if you're sure that it's Staph aureus, then our antibiogram has 97% stability for sulfamethoxazole trimethoprim or Bactrim, so that would be a good first-line recommendation agent for a skin soft tissue infection. However, if you're not sure that it's only Staph aureus that is a contributor, Bactrim will not be an ideal agent because of its poor activity against streptococcus. So if you think there's a component of strep, then clindamycin may be more of an appropriate option. These that are available, so IDSA has a lot of guidelines, so does the American Academy of Pediatrics Support. The Centers of Disease Control have a lot of information on antimicrobial stewardship, and then we have a Rainbow Babies and Children's internet website that has treatment guidelines, our antibiogram there, and different dosing recommendations. These two quotes, how we use antibiotics today are in one patient directly impacts how effective they will be tomorrow, or another patient, they are a shared resource. And if you're going to use antimicrobials judiciously, you might as well start planning for the post-antibiotic era. Questions?
What are your thoughts on using some physicians need it, they get
Yes, question was, what are my thoughts on Omnicef or ceftonir for acute otitis? There was recently a publication in AP determining that Omnicef is as equivalent to ampicillin for acute otitis. So in general, I don't really like Omnicef. So the cephalosporins have very poor bioavailability. But for acute otitis, it has retained its susceptibility for those organisms that we're worried about. So for H flu and for that strep pneumo. For pneumonia, I wouldn't like ceftonir. So for otitis, I think it's okay. It's one of the one times I'm like, okay, it may be good, but for the most part, I do not think it is an ideal agent. And if it is used, I will always recommend using the 2-time-a-day dosing. A lot of people see that once a day and they're like, oh, I'm just going to use this because it's once a day and it's easier. But it's better to give that 2 times a day because it's a beta-lactam, and so you want to make sure your time above that minimum inhibitory concentration, so your MSC, you want to maximize that. So the more frequently you dose it, you're maximizing your effectiveness. So I do it for acute otitis. I would use it for anything else, and always do the 4 per kilo twice a day instead of the 8 milligrams per kilo once a day. Yes. The question was, do I believe anecdotally that too many antibiotics are being used? Yeah, there's a lot of studies that survey multiple providers, and so all providers will say, I do think that there's overuse of antimicrobials, but I do not think that I'm contributing to that. So everyone wants to say, I think that I use them appropriately, and we all think that, you know, you're doing the very best thing for your patients, but we know that 50% of that is inappropriate, whether that is the wrong dose, whether they have a group A strep that's negative and they say that, oh, well, the sister has strep or something like that. So all of those things do lead to inappropriate use. There are a lot of pushes to, which I don't know if I really agree with, is to tie antimicrobial prescribing to reimbursement. So they have institutions where they give every provider a scorecard, and they say that you had this many antimicrobial prescriptions, whereas your card with the same diagnosis had this many. I don't think that's necessarily the right way to go, but I do think it brings attention to people's prescribing habits. But you know, I do think that we use way too many antimicrobials, and even if they have an initial infection, I think one of the things that we really struggle with is duration. So NIMA is a good case for that. So we recommend 10 days, even the guidelines say there's not an ideal time frame for that, but there's been studies that show that 7 days may be appropriate. Then, and you think of the adult literature, they will always do like 14 days for pseudomonal pneumonia, and that's even been cut down to 7 days. So I think that a lot of work needs to be done, or at least of limiting the duration of the antimicrobials, if anything, and putting a patient on an antimicrobial. Yes.
How do you feel about probiotics automatically administration with antibiotics?
The question was, how do I feel about probiotics and the push to put patients on them? And none are probiotics, and the reason for that is that in the studies, there's not one probiotic that is used for every study. So they have all these different bacteria that is in the probiotic. So I have no idea of, just as it worked in this study, this had Bifidobacterium, and this had a completely different one. Also, probiotics are not regulated by the FDA, so the amount of the probiotic agent is unknown. Then, patients with specific conditions, which is not really my expertise, like GI and things like that, I don't really know that literature. It may be some efficacy there, but in general, I feel like finding you don't need to really give probiotics. Some data that if a patient is on antimicrobials, give them probiotics to decrease the risk of C. diff, but children are really not at the highest risk for C. diff, so I don't really think that's appropriate either, and just over is more than enough without giving them an additional agent.
Especially with conjunctivitis, you treat just systemically, you also add that ophthalmic proper.
You initially can just treat systemically. You don't necessarily need the eye drop. I'll probably just try the systemic, and if it doesn't get better in 3 days, then you can consider adding local application as well.
What about the risk of or spreading it?
If they're getting systemic antibiotics, it should, yes. Yeah. The question was for with concurrent conjunctivitis, is systemic antimicrobials enough, or should you add on local as well? And I think that systemic should be fine. Any other questions? Yes, thank you. Thank you.